speaker, which is Bjerre from Denmark, that will talk about the risk of motor vehicle accidents in patients with an implantable cardioverter defibrillator, a Danish nationwide study. Jenny?
Thank you, Professor Brugada. So, I'm very pleased to be here today to talk about this study that investigates the risk of motor vehicle accidents in patients with an implantable cardioverter defibrillator. I have nothing to declare. So, implantable cardioverter defibrillators, or ICD for short, are used widely to prevent sudden cardiac death. We implant them both as primary prevention in patients who are at increased risk of a life-threatening arrhythmia, and also as secondary prevention for people who have survived a life-threatening arrhythmia. Ever since the very beginning of the ICD era, back in the 1980s, there's been much debate and concern on whether or not these patients should be allowed to drive a car. The concern is that the underlying condition may cause an arrhythmia and make the person lose consciousness while driving a car. And therefore, societies around the world have made recommendations on driving in ICD patients. And this here are the newest European guidelines from the European Heart Rhythm Association from 2009. And they state that, or they restrict ICD patients from driving up to 3 months following implantation or shock. And there really is little research on this area, and some of these risk estimations in these guidelines are based on data from trials that go back to as far back as the early 1990s. And moreover, we have very little data on the actual accident risk in these patients. So, while we on one side as physicians need to take into account the public road safety when we assess if these patients are medically fit to drive, we also have to acknowledge that these restrictions have a huge impact on the patient's quality of life and personal freedom. So we think that it's really necessary to have evidence on the necessity of these restrictions. In order to provide contemporary and real-world data on this subject, we aim to investigate the risk of motor vehicle accident following ICD implantation in a nationwide cohort of ICD patients, and then compare them to an age and sex-matched control population. The study was a retrospective register study. We used the nationwide Danish registries, and we studied all first-time ICD implantations from January 2008 until mid-2012. Each ICD patient was then matched with two controls of the same sex and age. The primary endpoint was fatal and non-fatal motor vehicle accidents. So, now to our results. These are the baseline characteristics, and the median age in our population was 66 years, and thus the same in the control population. They were predominantly male, and not surprisingly, the ICD population had more cardiovascular comorbidity and also more non-cardiovascular comorbidity. During follow-up, we observed a total of 280 motor vehicle accidents, and we found a significantly higher number of accidents in the ICD population compared to controls. Within the subgroups of ICD patients, we found that there was no difference between the number of accidents in primary and secondary prevention patients. Lastly, we did not observe any fatal motor vehicle accidents in the ICD population. This figure here illustrates the absolute non-adjusted risk of motor vehicle accidents. And on the x-axis, we have years since implant. And on the y-axis is the cumulative incidence of motor vehicle accidents, and it goes up to 5%. The black line represents the controls, the red line the primary prevention patients, and the blue line the secondary prevention ICD patients. And what we can appreciate is that until about 3 to 4 months, the lines are much the same, and then they begin separating. However, when looking at the absolute risk, it was low. in all groups, and the highest was 1.4% at 1 year in the secondary prevention group. And these are our main results, and this forest plot depicts the hazard ratio of motor vehicle accidents with the control population as reference. And we found, after adjustment for age, sex, and alcohol abuse, we found that a 51% increased risk of motor vehicle accident in this population. In subgroup analysis, we found that the risk was increased in both primary and secondary prevention patients, and there was no risk difference in between these two groups. So to summarize, in this nationwide cohort of ICD patients, we found a 51% increased risk of motor vehicle accidents compared with an age and sex-matched control population. We found no significant risk difference between primary prevention and secondary prevention patients. However, the absolute risks were low, and it was 1% and 1.4% in the primary and secondary prevention patients, respectively, at 1 year. Thank you for your attention.
Thank you, Jenny. Thank you. Professor Huber, you have some comments?
I think one question would be whether you think that the control population, even it was age and sex matched, is the correct group. Have been better to have a control population without an ICD implanted to at least have the same basic disease?
Very interesting point. It depends on which research question you want to answer. And what we wanted to describe was the risk of motor vehicle accidents in the ICD population. We're not investigating the risk of the ICD device itself. That we cannot conclude from this study. It would be, another good study would be to do as you say and find a control population who have the same disease and control combine them with the ICD population. But we've discussed this a lot, and I think it would be a very, very big risk of confounding by indication if you find patients who have the disease but of some reason were not implanted with an ICD. I would speculate that these patients would be very different. But good idea, absolutely.
Thank you. Before we move to the audience, let me clarify two things. One, the first thing is we're talking about that the motor car accidents as a driver. Is that right?
We have defined motor vehicle accident in this study as an accident that required admission to a hospital. We've used the hospital diagnosis codes.
But the patient as a driver.
We have no data in the study if the patient was driving. What we know from the Danish data is that in 80% of all cars, there is only one one person in the vehicle. And that is, of course, something we need to address. And I can tell you that right now we're doing a big nationwide questionnaire to all Danish patients, ICD patients from the last 5 years to investigate if they have experienced an ICD shock while driving as the driver of the vehicle.
Okay.
Yes.
So last question before moving to the audience. The question here is not whether the ICD by itself produces car accidents, but whether patients that have an ICD are more prone to have an accident than controls, because it's not a matter of that the ICD is firing at that moment and the patient gets a ventricular tachycardia or activation of the ICD, but simply because they have an ICD, they have a specific disease which is obviously at more risk than the ones that do not have the ICD. And is this what we are talking about? So that the population with an ICD, not because of the ICD, but because of the disease that finally produces that they need an ICD?
You're absolutely right. We speculate that this is the underlying cardiovascular disease and not the ICD device itself. But we will, and we are currently in the process of acquiring data on ICD therapy to be able to see if there are any accidents that are correlated to ICD shock.
Okay, thank
Notably.
you. Please, go ahead.
Dan Keller, Cardio Quote. Picking up on what Professor Brugada just said, is there any data on whether the ICD fired or not whether there was an event, or if, as you said, this population had more comorbidities, which would say, gee, we really have to expand the population to everybody with all these comorbidities. So I think it is important to know whether it's related to their cardiovascular disease, whether it's related to a shock or an event without a shock.
Thank you for that interesting and important question. So today, actually, patients who have an indication for an ICD, especially for secondary prevention, are restricted from driving for a period of time. And patients who have an indication for a secondary prevention ICD are prevented for ever driving for, truck drivers, bus drivers. They're not allowed to if they have an ICD indication, which is very important. And that also states that it is the underlying disease, not the device itself. And to answer your second question, we have data on ICD therapy, and we're currently working on combining these with the date of the accidents to see if there are any links there. Absolutely.
Please. Can we have the microphone, please?
So Marlene Busco from the Heart.org Medscape Cardiology. I have two questions. The first one is about the timing of these of the accident, I guess, because you mentioned the guidelines, something about being restricted for the first 3 months. Do you have any idea in your study how long these patients had been implanted, and are the guidelines correct? Is this the right amount of time, or does this differ in the United States, for example? That's my first question.
Okay, so yes, the guidelines in Denmark during the study period were the same as the current US guidelines, and that is actually 6 months following implantation for secondary prevention, and 1 week to 1 month after primary prevention, and also 6 months following a shock. Those are the guidelines, and we saw that there were actually accidents in that period. And I think it's important to know as well that unfortunately we have, from previous studies, we know that many ICD patients drive even though they have been advised not to by their physician. So
maybe let me add something here, because the guidelines were restricting for the 6 months because of the fear of having a shock. This is completely different. Here we are talking that the patients that wear a defibrillator because of their condition that is leading them to have the defibrillator are at risk to have more car accidents, probably because of the disease itself. This has never been considered in the guidelines like that, because if this is true, then we have to restrict conduction also to the patients that have the disease at the same level, although Professor Huber was asking for this control, which is not ready now, to know whether it is the disease itself or the defibrillator, because the guidelines were restricting for the fear of shock, not for the fear of having a car accident because of the disease. So we have to take care of that.
My follow-up question is sort of related. Is there a mandatory reporting, like the cardiologist has to report, I don't know where, that the patient has an ICD and should not be driving?
I'm not sure how that works in the US. In Denmark, it's noted in the patient chart, but it's up to the patient to follow the recommendation, and the consequence for the patient is that if they have an accident, they will be responsible for it in terms of insurance, etc.
Thank you. Yeah, last question, and we move to the next one.
From your graph, it looks like the safest time to be driving is the first 3 months because they don't diverge until after that.
Yes, well, that's good observation. And you can speculate that that is because these patients are not driving at this point. Maybe they are actually following the recommendations.
Okay, thank you very much.